Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We are in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
I'll start. I can't see our fourth panelist, Hindu team. So I think he'll join us soon. So a very good morning, everybody, and welcome to the penultimate episode of the 15-part health series organized by the Hindu in collaboration with Naruvi Hospitals, Vellore, as part of the Healthy India, Happy India initiative. Today's topic for discussion is vitamin D deficiency, myth versus reality. It is common knowledge that when our skin is exposed to sunlight, the body produces vitamin D, essential for bone health and calcium absorption. But due to our lifestyle changes and habits, many of us do not get enough exposure, and vitamin D deficiency leads to health problems such as rickets in children and osteomalacia in adults. To discuss the topic in detail, we have our panel of experts, whom I will introduce now. Our first speaker is Dr. Kurian Thomas, Senior Consultant, Physician, and Clinical Epidemiologist at Naruvi Hospitals, Vellore. He is former Professor and Head of Department of General Medicine at Christian Medical College, Vellore, and was also with Pondicherry Institute of Medical Sciences. Dr. Kurian did his MBBS from University of Bangalore St. John's Medical College. He studied medicine and surgery from University of Kerala, Trivandrum Medical College, and did his MD in general medicine from McMaster University, Canada. Dr. Kurian began his professional career as a consultant physician at TMM Hospital, Tiruvalla, Kerala, and moved on to CMC Vellore, where he worked for 3 decades from 1985 to 2014. For the next 8 years, he was the Director of Research with Oman Medical Special Board in Muscat. He has long years of experience in acute medicine, emergency medicine, and intensive care. And he also has special interest in infectious diseases, rheumatology, respiratory diseases, and poisoning. Dr. Kurian has also been the professor in charge of undergraduate and postgraduate students teaching in MGR Medical University, Tamil Nadu, and also at University of Pondicherry. He was member of International Clinical Epidemiology Network and coordinator of Inland Infectious Disease Initiative in India. Dr. Kurian has held multiple posts and responsibilities, such as the president of Indian Clinical Epidemiology Network, member of the National Core Planning Team, and he has been instrumental in planning National AIDS Control Program. He has worked as World Bank consultant for Integrated Disease Surveillance Program in India. He has been member of Global Alliance on Antimicrobial Resistance and Policy during 2012 and 2015. Dr. Kurian has traveled to multiple countries and been on the editorial board of several medical journals. In 1999, he was awarded the Career Scientist Award from International Clinical Epidemiology Network, USA. Dr. Kurian will now speak on myths and realities in vitamin D related to bone and mineral metabolism. We are keen to hear you, Dr. Kurian. Welcome.
Thank you. Can I have the presentation? Thank you very much for the introduction. I'm going to talk to you about the myths and realities in terms of, because as just now we have been introduced, there's a whole lot of information regarding vitamin D, which we know we need to understand. Why exactly are we dealing with an epidemic of vitamin D deficiency and wide range of prescriptions when actually it's a vitamin which is even possible to be made within the body with the help of ultraviolet light. So to understand it further,
So we are not able to see your slides.
I see. Can you see it now?
Yes, sir.
Yeah, to understand it further, let's go back or understand what vitamins are. Vitamins are essential compounds which are necessary for cell function, growth, and development. It is a micronutrient, and that means essentially body needs them in very small quantity. There are really two types of vitamins, water soluble and fat soluble. It's important to note that vitamin D is a fat soluble vitamin, and therefore it is not easily excreted by the kidney, and potentially it can give to toxic levels in the body. As we just heard, that understand that vitamin D it's called the sunlight vitamin. It is synthesized in the body when it's exposed to sunlight. Then why we wonder, why is that there is an epidemic of vitamin D deficiency in the community, and why is there testing for vitamin D levels are so common across health clinics and hospitals? We have heard that deficiency is associated with many types of diseases, and we wonder why. Is there any reason that everyone should be taken for have vitamin D supplements? What is the truth behind these? And are these healthcare behaviors based on scientific evidence? So to understand it, the vitamin D deficiency and the clinical syndrome of rickets has been described from very ancient times in the 16th century itself, that it was associated with calcium homeostasis and bone mineral metabolism. It produces, you heard, rickets in children. Essentially, I've shown you a picture of rickets where the child with bent bones, because the softening of the bones, and osteomalacia in adults. Fortunately, rickets is rarely seen except in associated with severe malnutrition in the setting of starvation associated with wars and famines in the world. Except rarely, we are also seeing this as part of a genetic disorder with phosphate metabolism and part of renal disease. So why is a micronutrient requiring in small quantities and made from the body the necessary to be replaced? The daily requirement, as you said, is in nanograms. In 50 nanograms expressed in international units will be around 600 for most children and adults, and 800 international units for the elderly population, and 1,000 international units. That means 25 nanograms per pregnancy and lactation. So the deficiency has to be understood. We have to understand the nature of the metabolism of vitamin D. I'll show you a slide which is a little complex, but I will highlight what is essential to be known in this. The first is that the body synthesizes vitamin D with ultraviolet light from cholesterol molecule and produces vitamin D3. And it's also available from the food, particularly non-vegetarian food like fish, meat, egg, etc. Vegetarians get their food, which is a very similar molecule called ergocalciferol, which is mainly from vegetarian food. But they are just pre-vitamins. They are not active and quickly converted in the liver to a 25-hydroxy vitamin D, which is partly active. Even this is only partly active. The active component is called vitamin the dihydroxyvitamin, 125-hydroxyvitamin, which is made in the kidney, and this have a half-life of relatively a few days only. And therefore, you can see, I just showed this to show that multiple levels of involvement is there in the vitamin metabolism, and any pathway deficiency could give you a deficiency in the individual. Which is the best source of vitamin? As far as fish, among the dietary source, fish is the richest source of vitamin. Fish oil particularly can be as a very rich source of vitamin. Meat, eggs, liver are also high. But for vegetarians, it is a little hard to get. In small quantities, and almonds, mushrooms, and milk, etc., are available. But it's not possible to consume them in large enough quantities to meet our requirements. Therefore, and in addition, the problem is that what we take, 20% of this vitamin D is only absorbed, particularly, and even smaller amount when there is an existence of vitamin D deficiency, which is the primary responsible for absorption from the gut. So most of our requirements is from the internal conversion of cholesterol in the skin converted through the action of UV light. There is a consensus state levels. This has been described by many authorities that severe vitamin deficiency is less than 12 nanograms per liter of blood, and deficiency would be said around less than 20, insufficiency in the range of 20 to 30, normal level 30 to 50. and toxic between 75 to 100 nanograms per liter. But how did they come to this is an important point that needs to be understood. It depends on how different people have looked at it. For example, physiologists who are looking at absorption of vitamin D from the gut, which is the calcium from the gut as the outcome, found that at levels very low, less than 12, the absorption is grossly affected. 12 to 20, it is affected to some degree. So they have put the value at 20 as an important part of vitamin D deficiency. When looking at endocrinologists who are understanding about calcium metabolism and calcium homeostasis, when calcium level comes down, parathyroid hormones is elevated and they generate calcium from the bone, making the bone thinner. So endocrinologists found that parathyroid levels are elevated when you have associated with vitamin D deficiency between 20 to 25 nanograms per liter. But when you look at clinicians, particularly geriatric people associated with bone fractures, even at levels of 30, increased bone fractures seem to happen. So these are the levels that we have, by consensus, people have understood. So therefore, using those levels as the cutoff points, the prevalence of vitamin D has been noted by many epidemiological studies in India that less than 20, that means moderately severe vitamin D deficiency occurs in 50 to 80% of the population. And less than 30 has been reported in many studies above 80 and some studies even almost 100% of the population in certain population groups. It is not a problem only in India, but even globally, even where the nutrition is much better, levels of less than 20 is in the range of 50, one step higher, but in less than 30 is in 50 to 80%. So it is a global problem, particularly even so in India. And high-risk groups but this will be spoken to, Anish subsequent speaker will speak further on this, so I'm not going into it, but vegetarians, elderly population, renal diseases, etc. are higher levels of vitamin D levels and deficiencies are to be understood to be present. So there the question is vitamin D deficiency in epidemic proportion? The answer is yes. Globally and in India, it is true. Less than 30 is around, as you said, around 80%, less than 20, around 30 to 50%. What are the probable reasons why they are? It is not fully understood that what are all the reasons that, because there are pathways could be blocked in very many levels. But perhaps some of the important ones are listed here. Environmental pollution result in UV lights exposure coming down less and allowing us to convert vitamin D less in the synthesized vitamin D less. Lifestyle issues with poor exposure to sunlight, either used to clothing or your own staying indoors too much. A majority have vegetarian diet. Even those who take non-vegetarian diet, the majority take very occasionally only. So in Indian diet is very particularly low in vitamin D. Lack of fortification of dairy products in India certainly is one of the reasons. Comorbidities because we are diabetes and metabolic diseases are very common. They all lead to renal diseases and fat malabsorption in the intestine. All could contribute to the vitamin D deficiency. But at this point, I must say that it's not fully understood why vitamin D deficiency is so prevalent in India. So is it necessary to treat everyone? Perhaps the answer is no. Certainly routine and repeated testing everyone in the clinic is not necessary. But we would test all high-risk population, elderly with symptoms of muscle and bone pain, people who are prone for falls and fractures, those are on pure vegetarian diet, lifestyle causing poor exposure to sunlight, etc. But in my own view is that those coming, because the prevalence is so high and it is associated with toxicity, etc., those coming for routine checkup and requesting for vitamin D levels should also have justified in testing. I'm just understanding the advantages and disadvantages of testing as a method. Testing will be able to detect asymptomatic deficiency and be identified and treated. Unnecessary medication can be avoided in those who have normal levels. and help to identify those with toxic levels to prevent complications because it is a fat-soluble vitamin. And the disadvantage is at the level of population testing, it costs a heck of a lot of money. And that is a negative point related to testing and treating as a strategy. Toxicity, again, I would think, and Dr. Subsequent speaker will speak about, but being, as I said earlier, fat soluble is associated with higher levels and it's not easily cleared by the kidney. If you give in excess, it produces toxicity. Some of the common symptoms of nausea, confusion, lethargy, even muscle weakness, convulsions, and certain cancers are also have been associated with it. So what are the two alternate strategies that we have? Do we have a better option? The current strategy, as he said, is testing and treating individual level. But we have an alternate strategy of fortification of food at population level, as in many developed countries. And which is better? Number of economic evaluations have been done in Germany and in Europe and USA, which clearly shows that fortification of milk and milk products is associated with reduced bone fractures in the elderly. Higher blood levels of vitamin D can be obtained in the population level than by testing and treating strategy. In Germany, they clearly showed that significant cost saving, because of course all healthcare is being by the government. It has gave them considerable cost saving is associated seen in German study. The Indian scenario, we have a pilot study was done in Gujarat, revealed more or less similar kind of picture. But currently, only voluntary fortification of orange juice and some products available in the shelf of big markets. No mandatory fortification is currently available in India. So essentially, because there is acceptance, there is lack of acceptance for this strategy in many places. And of course, if you do a fortification, we need to have the infrastructure to test for potential toxicity at even remote areas of the country, in many health areas. So these are absent at this point. So maybe we may have to look for that in the future. So let us go back and say, what are the myths and reality? Most of what we hear about vitamin D deficiency related to bone and mineral metabolism is true. Vitamin D deficiency is seen in epidemic proportions in the community. Daily requirements are not met by diet alone and internal conversion. There's large asymptomatic population with deficiency. High-risk groups have been identified requiring special care, and deficiency associated with muscle, bone pain, falls in the elderly, immunologic and inflammatory diseases. So public health interventions or food fortification may be a good option in the future. I leave you with a slide, which essentially is what I follow in my clinic. When there is moderate to severe deficiency, I certainly replace with high dose of vitamin D in the initial phase until the levels are corrected. When you have in the 31 insufficiency level at 31 to 50 depends on whether there is a high risk group or non-high risk group. Non-high risk group is treated with high dose for till correction, and then replacement is given. When it's above normal levels of 50, very often only replacement is necessary. And toxic levels, we require to stop all tonics and for calcium replacement, check calcium level and treat for toxicity. Testing and treating is the only available strategy in India today, and this avoids unnecessary treatment and toxicity. Therefore, this is the strategy that we follow now. Thank you very much for the time of listening.
Thank you, Dr. Kurian, for that wonderful presentation. We'll quickly move on to our next speaker, Dr. Pranita Vanjare, consultant in geriatrics and internal medicine with Naruvi Hospitals, Vellore. She will elaborate on extraskeletal manifestations of vitamin D. Dr. Pranita did her MBBS from Christian Medical College, Ludhiana, and MD in geriatric medicine from Christian Medical College, Vellore, and followed it up with MRCP in UK. Dr. Pranita's areas of interest include movement disorders in elderly, bone health and osteoporosis in older adults. Prior to her joining CMC Vellore, she worked in Christian Hospital, Berhampur, Odisha, and Evangelical Mission Hospital, Baitalpur, Chhattisgarh. Over to you, ma'am.
Thank you very much for your kind introduction. So I will be speaking on vitamin D deficiency as a extraskeletal diseases. Uh, we are here to talk about vitamin D deficiency because, as we have heard from the previous speaker, that it is very much prevalent in world as well as in our own country. The prevalence ranges from 40 to 90% in our country. Why is it so? So the Indian diet failed to meet the daily requirement of vitamin D, and we don't have any fortification of vitamin D in our food as compared to the Western standards. Vitamin D deficiency has many consequences which are still being explored. This is the slide which is showing the high prevalent of vitamin D deficiency in our country. This including the South India, North India, the Central as well as the Western India. And we see that the children in the age group of 16 to 18 as well as the women in the childbearing age are and older adults are the one who are more prone to get vitamin D deficiency. Is vitamin D only for bone? So the studies have come up, some of the studies, and found association with other diseases also. So vitamin D is not just for bone, it is more than bones. There are molecular and animal studies that have established association of vitamin D with extraskeletal diseases. We already know and we already heard from the previous speaker, there is a very strong association of vitamin D deficiency with the bone health. However, with the extraskeletal diseases, its causation is still under study. So, to say that the vitamin D has a very active role in causation of other diseases, we still have no clear evidence for the same. Why is it important to look at vitamin D in other organs and how this concept of vitamin D in other organ has come? It has come mainly from the genetic studies where we have found that the vitamin D receptor is universally expressed in nucleated cell. Studies have found that around 3% of human and mouse genome is under the control of active form of vitamin D. We have seen in the previous speaker's slide that the activation of vitamin D happens in the kidney, but there are 10 more tissues where they are able to convert vitamin D to the active form by the help of the enzyme. So it is much uh, beyond bones. It is also affecting the other organs. Thus, the spectrum of vitamin D endocrine system is much broader than calcium homeostasis. I will be going on few aspects of vitamin D where we have found in some of the studies that there is an association of vitamin D deficiency with these diseases. So the first and the foremost important is the muscle and prevention of falls. Severe vitamin D deficiency causes myopathy, which is characterized by the muscle weakness, wasting, and instability of gait. Vitamin D is essential for our balance, and which itself is a independent predictor of fall, especially in older adults. Some of the studies have found that supplementation of vitamin D in older adults have reduced the fall by improving their muscle function. The greatest benefit has been observed when they have severe vitamin D deficiency as by 10 nanogram per milliliter, and therefore the American Geriatric Society recommend higher supplementation of vitamin D for elderly to reduce the risk of fall and fracture. The uh, next association is in the cardiovascular and the heart health. Some of the studies have found that vitamin D may help regulate the blood pressure and prevent heart diseases. It has shown to be associated with metabolic syndrome, hypertension, and adverse cardiovascular events. Some studies have found the link with low vitamin D levels and high heart problems. However, more research is needed to confirm if the supplementation directly helps. It is considered as one of the novel risk factor, but the current evidence does not strongly support screening for vitamin D deficiency in a patients who are established heart problem or who are at a risk of heart problem. Next, coming to the metabolic syndrome or diabetes, there is due to the anti-inflammatory action of vitamin D, it has been found to play a role in prevention of type 1 diabetes. Some of the studies have found that the people who are pre-diabetes and who are given a vitamin D supplementation, they have reduced the occurrence of diabetes by around 3.3%. These are observational study, and therefore we directly cannot link vitamin D supplementation or treating vitamin D deficiency with diabetes. In immunity, vitamin D has been studied against treating against respiratory tract infections because of its anti-inflammatory action. And it is found that taking vitamin D supplementation in a people who are deficient in vitamin D reduces the risk of respiratory infection. There are several ongoing trials to clarify the possible beneficial effect of vitamin D supplementation on infectious diseases. So, it has also been linked with chronic obstructive pulmonary diseases and asthma exacerbation. Vitamin D also has been linked, D deficiency has been linked with autoimmune diseases like type 1 diabetes and rheumatoid arthritis, multiple sclerosis. Some of the trials have shown that the supplementation of vitamin D reduce the risk of autoimmune disease, especially in older adults. Similar studies also have found association between rheumatoid arthritis and vitamin D. Cancer risk reduction, that is the another aspect of vitamin D deficiency, because vitamin D might help slow the growth of some of the cancer cell and inflammation. There is some evidence linking the higher level of vitamin D with lower incidence of colon cancer, breast cancer, and prostate cancer. At this point of time, there is not enough data to support a significant role of vitamin D supplementation in preventing or changing the course of breast, colon, or prostate cancer. Vitamin D has been shown to improve mood and mental health. There are studies which has shown that the vitamin D deficiency has been linked to depression. It also affects the mood by affecting certain brain chemicals like serotonin. The British Journal of Psychiatry show a significant association between low vitamin D level and depression. The vitamin D supplementation is required, as we seen in the previous slide, only in higher risk group when the screening and the supplementation is required. This will be taken by the next speaker. I would say in my summary that vitamin D is not just for bone, it supports the whole body. But at present, there is no clear evidence to support the causation of vitamin D deficiency with all these diseases. There is more investigations is needed to determine whether vitamin D status can optimize to improve other aspects of human health. However, we do people who have vitamin D deficiency or insufficiency should receive vitamin D supplementation. At present, there is no direct recommendation to screen vitamin D deficiency in all of these major diseases, which I have explained in cardiovascular diseases or metabolic diseases, except in the higher risk group. There is no recommendation also to supplement beyond what is required for bone health. So I would say that it is not a myth to say that vitamin D is associated with extraskeletal diseases. However, there is no direct causation which has been found. So these are still under some of the studies. Thank you. Thank you for your patience hearing.
Thank you, Dr. Pranita, for that very interesting presentation. As we move on to our final speaker for this webinar, I would request our attendees to start posting their questions in the Q&A box, which is open for you. Dr. D. Anish Bashir, Professor of Medicine at SRM Medical College Hospital and Research Center, Chennai, is also a consultant with Naruvi Hospitals, Vellore. His presentation is on high-risk groups and vitamin D deficiency. After completing his MBBS from Trivandrum Medical College, Dr. Anish did his MD in internal medicine from JIPMA Pondicherry, and he did his FRCP from Edinburgh. In the last 10 years, Dr. Anish has worked in multiple hospitals and health institutions. He has published 80 papers in national and international peer-reviewed medical journals, and he has also taken UG and PG students teaching classes. So over to you, Dr. Anish, for your presentation. Dr. Anish, you have to unmute yourself. Unmute. Yeah, thank you.
I'm extremely sorry. Yeah. So thank you for the introduction and also for this opportunity. Professor Kurian as well as Dr. Pranita has already mentioned to you about a few high-risk groups. This was being brought up repeatedly. And so I will focus in the next few minutes, particularly on these high-risk groups and what is the role of vitamin D in these groups. So we will quickly be going through what are the high-risk groups, what is the evaluation needed in these groups, and the vitamin D replacement in these groups, and something about monitoring and adverse effects of vitamin D in these populations. So one important high-risk group is obviously older persons for reasons that as we age, the ability of the skin to generate vitamin D from sunlight decreases, as well as there is very poor intake related to aging process as such. And this risk is increased if these people stay most of the time confined to indoors, as is often the case. And the risk is higher for people who live in northern latitudes, again for obvious reasons, again because of lack of exposure to sunlight and the weather. The other group of people are those who are on certain medications which might affect vitamin D metabolism in the body. I'm listing only a few. There are a lot of medications, but it will be good to check with your individual physician about these. But generally, phenytoin, which is a drug that is used for epilepsy or convulsions, carbamazepine, another drug which is commonly used. Again, some of the drugs used to treat tuberculosis. So and there are other drugs as well. So these could affect the vitamin D metabolism. People who are hospitalized for various reasons, like inpatients, particularly in the general medical wards. Again, these may be because of certain kind of reporting bias or testing bias as well. So we don't really know, but these groups have been found to have a higher incidence of vitamin D deficiency. institutionalized persons, in the sense that people who live in care homes and orphanages or under care of other people. So these may also, so again, for obvious reasons, the diet may not be adequate, their exposure to sunlight may not be adequate. So many other factors. And due to lifestyle and due to sedentary indoor activities and use of protective clothing, consistent use of full sunscreens, so these might affect our exposure to sunlight. Osteoporotic people in general, osteoporosis, which is a bone weakening condition, again, you can have an increased risk of vitamin deficiency. Hyperparathyroidism, which is a condition where your parathyroid glands, which are concerned with calcium levels in the body, maintaining calcium levels in the body, might be overactive. And a huge list of, there is a lot of diseases under this, but I am listing only a few, like those who have undergone bariatric surgery for weight reduction or fat reduction, for obesity. Then inflammatory bowel disease, which is a condition that affects the intestines and will lead to decreased absorption of a lot of substances, including vitamin D. Celiac disease, which is again a disease that is associated with decreased absorption of the vitamin. And liver disease, again, Dr. Kurian showed you a slide where there is a step of activation that happens in the liver and then in the kidney. So the activation of vitamin D needs the liver involvement. And for other reasons, such as because it's a fat soluble vitamin, again, if there is a problem in the bile secretion due to hepatobiliary liver disease and bile tract disease, again, you can get vitamin D deficiency. And of course, people with chronic kidney disease, like again, you have seen that the ultimate step of activation of the vitamin D happens in the kidneys. So again, that is an important factor that can affect vitamin D levels and cause vitamin D deficiency. And in general, people with chronic kidney disease also suffer from problems with absorption, problems with the dietary intake. So in general, appetite and all those things contribute to decreased levels. So who need testing for vitamin D? This has already been again discussed by the previous speakers. So not all people, the routine screening of the entire population is not indicated. For asymptomatic adults in particular, and even during pregnancy, it is not required. But again, normal risk adults means those whom we have who don't fall under the category we mentioned, but high risk groups will require measurement of vitamin D. And it is good to also know how much is needed to supplement to reach a target level. And you can remeasure the levels after 3 to 4 months of supplementation to see if you have attained the target levels. So these groups in general will require vitamin D testing. Pregnant women, as I have told you in the beginning, there is no testing required for a normal pregnant woman unless they are obese or they consistently wear protective clothing or their exposure to sunlight is very, very low. And apart from testing vitamin D, some groups of people will need further evaluation, like other tests to be done. And these groups include patients with levels of insufficiency. So we discussed about deficiency, insufficiency. These are relative terms, but again, cutoffs vary. But based on that, who are just having insufficiency generally don't require additional evaluation. But if it clearly falls in the category of severe deficiency, they are at risk of developing osteomalacia and other problems, especially falls and fractures and all that. So they will require measurement of other blood levels of tests. Usually we perform calcium, phosphorus, alkaline phosphatase, the parathyroid hormone levels, electrolytes, and blood urea nitrogen. So all of these or some of these tests may be indicated depending on what your physician thinks based on your examination and other risk factors. So in these group of people, in patients with severe, moderate to severe deficiency, additional testing in the form of these tests may also be indicated. So the other test which we usually do to assess how fragile the bone is, that is called the bone mineral density evaluation, or it's also done using a scan called DEXA scan. Some of you might be aware of it, but again, it is not routinely needed for just low vitamin D alone. if the patient is known to be osteoporotic, and then you are going to supplement vitamin D, then it may be helpful in identifying the impact of treatment by doing the scan before and after the supplementation. Otherwise, routinely it is not indicated. Now, this also has been touched upon. I'll just mention the different forms of vitamin D. As we said, we have two forms, vitamin D3 and D2, cholecalciferol, ergocalciferol. In terms of efficacy or superiority of raising the levels, actually the cholecalciferol is much more efficient than ergocalciferol. So that is what is usually preferred for supplementation. And it is usually available in 400, 800,000, 2,000, 5,000, 10,000. In India, 60,000 unit capsules are usually available. Intramuscular injections are available in some countries, but they're generally very painful, not usually advised, and not needed as well most of the time. So these are the usual strengths that we have, and most commonly we in India 60,000 is the one which is commonly available. 40 is also available in some places, 20, 10 also. So as I said, comparison of efficacy, usually cholecalciferol levels increases the levels of vitamin D much more efficiently than ergocalciferol. So that is what we prefer for supplementation. So during pregnancy, again, if it is the person has no additional risks, 600 international units is usually for the reproductive age woman, but during pregnancy, you may need to increase it up to 1,000 international units if it is not being provided by the diet, which is usually the case. So in chronic kidney disease also, again, if the patient is having by definition a chronic kidney disease, but he doesn't have any other manifestations of severe renal disease, then the usual supplementation might be sufficient. But if the disease is progressive, patient is on dialysis, patient is on renal replacement therapy, then patient will need the high dose, that is the 60,000 units weekly for about 4 to 6 weeks, and then followed by daily dose of about 800 international units to keep the levels stable. So that is for kidney disease. And in kidney disease, the other problem is that there might be issues with activation of the vitamin. So in patients who may not respond to just supplementing the vitamin D, you will have to sometimes give the active form, that is the calcitriol or calcidiol, which Professor Kurian had shown in the slide, the last activated metabolite. So they are also available in the market, but a bit more expensive and not very easily available. But in patients who don't respond to high doses of vitamin D, we may have to use calcitriol or calcitriol. Again, for malabsorption and liver disease, we will need higher doses of vitamin D to be given, like 10,000 to 5,000 units daily. So the usual replacement dose is about 800 international units, 800 international units, 600 to 800. But here, if you see, it is like much higher than that, for 10,000 to 50,000 units daily. And especially for patients with gastrectomy, means a part of the stomach has been removed, or if they have problems with absorption, the diseases that I had listed, celiac disease, inflammatory bowel disease, even liver disease and all that. So in case these patients, even the higher doses are not getting absorbed, because the absorption is only about 20% of what we take. So still not being, so in malabsorption it will be even less than that. So if it is not working, then we'll have to use the active metabolites, means the form into which the body converts them. So those forms are available, like calcidiol or calcitriol, that can also be given to these patients, so that it will raise the levels adequately. Again, as I mentioned, the cost as well as the availability is a factor for these substances. The other option for people in whom the levels are not coming up despite giving high doses is, again, sun exposure, sun lamp exposure, ultraviolet light exposure. All these can be done. But again, you have to balance the problems associated with excessive ultraviolet exposure versus the benefit in these cases. It has to be very carefully chosen and only done in centers with expertise in that. So monitoring vitamin D levels, once you start vitamin D for patients. Again, you routinely you don't need to test for like whether it has increased or not. If you are just starting it for people who are at normal risk, that is who don't fall into those risk categories. But those in whom you are starting it for moderate to severe deficiency, you will have to wait for about 4 weeks. Like you give the 60,000 units weekly once for 4 weeks, and after about 3 to 4 months, you will have to repeat the vitamin D levels just to see if that you have attained the target blood levels. And if it is not coming up, then you might have to increase the dose, or you might have to use alternative strategies that we have mentioned, or try to find out if there are any other factors that are affecting the vitamin D absorption. Now, vitamin D supplementation is not without any problem, because as the previous speakers have said, that it is predominantly a fat-soluble vitamin. So it is stored in the body, and it is also not filtered easily by the kidneys. So it stays in the body for some time. So if you continue to take large amounts, it may not be a good idea. One thing that we need to be aware of, especially the elderly, is that you need to have supplement awareness. Means like you might be taking a lot of supplements for several other conditions. It might be just multivitamins, but we don't know if these multivitamin supplements contain vitamin D, and if so, in how many, what amounts. So over a period of time, the vitamin D can accumulate in the body and lead to problems. So it's always good to check if your vitamin supplements, multivitamin supplements, contain any amount of vitamin D, if you are regularly taking these supplements. That is one important thing. The other problem, not very common, but can occur in people who are taking extremely high doses of vitamin D, particularly for the high risk groups that I mentioned, like the people on with chronic kidney disease, liver disease, and malabsorption. There may be a chance of people going into vitamin D toxicity. Also, people who consume a lot of supplements in high doses. So these two people are at very high risk of developing this toxicity. What is currently known is that the safe upper limit is around 4,000 units a day maximum. So beyond that is a risk factor for toxicity, and generally in the normal risk population, we never go beyond this level for supplementation. So this is what is usually considered as safe maximum level. And symptoms have been listed previously, but most common symptoms include confusion, lethargy, sometimes excessive thirst, excessive urination, and even convulsions or muscle weakness can sometimes occur in severe toxicity. And treatment involves, once you identify, you stop the supplements, try to find out what is actually the source of vitamin D. Is it the one that you are taking without knowing, or is it the one that you have been taking as part of your supplementation? Stopping it, and continuous adequate hydration. Okay, and if patient develops symptoms of seizures and all that, treatment has to be given for that. Some patients may require kidney support and other measures. So to wind up with some take-home points, so don't screen everyone. That is what everybody has been saying. So test and treat. The high-risk groups need to be identified, and they need to be tested as well as treated. The supplement of choice is cholecalciferol, and the dose I have mentioned is about 600 to 800 units a day for the insufficiency. And if it is a severe deficiency, then you need to give 60,000 units weekly for 6 weeks, 4 to 6 weeks, and then daily according to the usual dose. The high risk groups, like especially those with kidney disease and liver disease, malabsorption, they will need the same weekly dose, almost the same weekly dose, to be given as daily dose, like 10,000 to 60,000 units, even daily, will be required. And then once the levels are adequate, you can switch over to a supplementary dose. Additional testing, like the ones I have told, calcium, phosphorus, alkaline phosphatase, parathyroid hormone testing, may all be needed only in certain group of patients, which we have discussed before. And toxicity is not very common, but one needs to be aware of this problem and always try to avoid supplements that If you are not needing vitamin D, then make sure that your supplements don't contain unnecessary vitamin D. So with that, I'd wind up the session. Thank you for your patient listening, and thank you for this opportunity.
Thank you, Dr. Anish, for that very informative presentation. I will straight away dive into questions because we have less than 15 minutes left and there are tons of questions. Dr. Kurian, I would like to start with you. You know, like all three panelists have, of course, mentioned that vitamin D deficiency exists like an epidemic in our population. At the same time, you have highlighted that it is kind of asymptomatic in many patients, and also it does not require mass screening or mass testing. So I want to know why, because, you know, like if it is asymptomatic, so why can't we include it in like our regular master health checkups, or like we have eye camps where we, you know, kind of find out who requires cataract? I mean, why don't we do it for vitamin D? Is it an expensive test to be done? Because why are we waiting for somebody to slip into a health complication?
The answer is when somebody comes to a hospital, nutritional advice, health advice should be part of a regular checkup. So instead of checking, if they don't have symptoms, you can presume you have the background information that 80% is under lower levels of vitamin D is present. But if they want to do a check, I said the group which requires a checkup for vitamin D, if they come and request, we will certainly do it. But one option is to give all of them advice regarding improving vitamin D consumptions in the food as one option other than testing. Testing is one option, but it is costly. When you consider testing 80% of our population is a little less advantageous than advising health advice for everybody. And hopefully many of them will be corrected by that. And certainly, but that anybody having any symptoms related to bone and muscle and with elderly and risk groups have to be tested. So this is an optional issue essentially related to the cost of testing at the public health level. When you want to test it, when you say everybody need to be tested, it's a huge population base that we are testing. Even though it is in individual, it is not a huge cost, but in societal level, it's a huge cost.
Dr. Anish, I'll direct one question to you because there are very similar questions. I'm clubbing them together. A lot of people have written that they have deficiency in vitamin D and they're taking this weekly dose of, say, 60,000 or 40,000 IU. But there is also a time span, I guess, to be followed. So, like, what are the risks? Somebody like Karthike is saying that he's doing it every week, and if it is fine to do, continue like this, or are there any risks involved?
Yeah, of course. The dose, as I mentioned, is like it is okay to take 60,000 units weekly, but that is only for the initial 4 to 6 weeks. And then after that, we recommend only a daily dose of the recommended daily allowance of RDA of what Dr. Kurian has said, are about 600 to 800 international units daily. So, and after this, you repeat the testing about 3 months later, 3 to 4 months later, and then if you see that the levels are in the normal thing, you can continue the daily supplementation for a few more months, and then we can decide on retesting if required based on symptoms and otherwise. And if your dietary intake is good enough and your sunlight exposure is very good, then probably you can consider stopping the daily supplementation. But if you still continue to fall under that risk groups that I have mentioned, that you have very little sunlight exposure, you use protective clothing, you regularly use full sunscreen, no, your activities are predominantly indoors, and then I guess we'll have to continue the supplementation. But that is a daily dose of a small dose, like 600 to 800 international units only, which is similar to the recommended daily allowance of vitamin D.
So is there something like once you have been diagnosed with vitamin D deficiency, be it at whatever age, so it means that it will keep happening, it will keep recurring, like you will take supplements for some time, you're okay, and then again you will have to give a gap or is it that, okay, once you have taken the dosage and you can maintain? Is there?
That's exactly what I was saying. See, the causes, why it is so prevalent in India is multifactorial, as Professor Kurian said. One, the identifiable risk factors that we know are related to sunlight exposure or indoor activity, use of clothing, and certain other conditions like malabsorption and kidney disease and all that. So as long as these no factors prevail, there is no other choice but to continue supplementation. But if at some point of time you are able to reverse these, like you are able to ensure that you get no at least 30 minutes of good sunlight exposure. Like the sunlight exposure, we most people misinterpret as like morning, you at 6 o'clock you go out and get sunlight exposure for half an hour is not the actual sunlight exposure that generates vitamin D. It is the sunlight that has the maximum UV penetration, which usually occurs somewhere around 10 o'clock to 3 o'clock in the afternoon, ideally when the sun is at the highest point. So all those things are a big problem for us to ensure. So that is why most people end up probably getting a lifelong supplementation. Otherwise, if you're able to do that, correct that, and ensure that your diet and sunlight exposure is okay, then we might be able to stop it.
Yeah, I'm glad you
There are
answered
also
that, because
many.
there are already a lot of questions about what is the right time to stand in the sun. Thank you. Yes, Dr. Kurian, you were saying something.
Yeah. There are also the level of deficiency at 80 to 100% suggests that there may be other unknown factors as well that is causing it. We don't have the full information as it. We have a list of causes which could potentially cause it, but there are still information that we need to understand why the prevalence of vitamin D deficiency is so rampant.
Dr. Pranit, I would like to bring you in. Like Sridhar Chari is asking, other than the danger of fractures and falls, what are the concerns in elderly population with respect to vitamin D deficiency?
So vitamin D deficiency is very common in older adults, and apart from we look at as a osteoporosis, that is the thinning of bones in the elderly. Apart from there is no major association which is found apart from the fall and fracture, but these are the very high risk group where we would like to screen for vitamin D deficiency and treat it as well to prevent the weakness of the leg, the muscle power. The another aspect is the weakness of the muscle, which causes the imbalance for them to fall. So apart from the main effect of vitamin D is in the muscles and the bone of the older adults, and it has been recommended to prevent the fall in elderly.
Uma Rao wants one of the experts to talk about the combination of vitamin K2 plus D3. How does it help? K2 plus D3 combo.
There is combination in the management, and I'm not sure. I've not heard anywhere where K2 vitamin D combination is better than vitamin D alone. I've not heard of it.
Right. Now, since we also talked about diet, sir, there are these two interesting points made by Syed Ahmed, who says that, for example, in Chennai, Arvin has introduced Arvin Delight brand, which is fortified with vitamin A and D. Then there are edible oils, which are fortified with vitamin A and D, and most of the brands, I mean, are having these two vitamins. So is it okay for the consumers to kind of have this particular?
The point about.
So you're not audible, sir. So you have to unmute.
Unmute?
Yes, sir. Now it's okay.
Yeah, the point about food fortification is potential. If you take it, once you start using a certain type of food, it becomes a habit. And therefore, potential for toxicity is present. And unless you are able to make sure that you are screening once on a regular basis, at least at a certain interval for toxicity, it is not an advisable thing for food fortification in general population who do not have, because once food is fortified, everybody takes it. Lot of food makes it available for those who need it and those who don't need it. And therefore, toxicity levels have to be monitored. And that facility, unfortunately, is available in the cities, but in many rural areas, this is perhaps not available.
And does it help to take cod liver oil capsules?
Cod liver capsule is a very high level of vitamin D. It's a fish oil.
Mm. So those can be taken kind
Yes,
of
yes.
without
Yeah.
prescription
Yeah, yeah.
safely.
It is a food source with high levels of vitamin D.
Sudarshan and Purnami are asking role of vitamin D in cartilage health and is sciatica associated with vitamin D deficiency. Dr. Anish, would you like to answer that?
Okay. Sciatica per se has nothing to do with vitamin D deficiency. Okay. So as Dr. Pranita and all have said, when there is osteoporosis, that is thinning of bones, it can lead to a lot of changes in the bone architecture. So they can lead to a lot of in layman terms, you can say the bone becomes sharp and the edges become sharp. They become spicules and all that, like very spiny processes. These can actually cause irritation to the nerves, and that is what is actually sciatica, one of the manifestations of that kind of. So the other problem is the discs can come out and press on the nerves, causing sciatica. So that is how it happens. So vitamin D deficiency per se doesn't cause this phenomenon, but because of that, when there is bone degeneration and problems, it can lead on to sciatica. If there is a degeneration or if there is a fracture at that point, it can cause. Cartilage also there's because it also requires the vitamin D, but there is no direct link with cartilage health and vitamin D, to my knowledge. It is mostly related to bone metabolism, the actual calcium hydroxyapatite. So that is what is usually involved in bone metabolism. So not
There are
sure.
multiple questions again on diet, and people want to know daily what should they take so that they don't get vitamin D deficiency. And a lot of things you've also addressed in your presentations, all of you, like why does it happen during pregnancy, or why does it? So I think I'll skip those questions because of shortage of time. But Kareem is asking, vitamin D deficiency is common in thalassemia patients. Is it so? And how can we overcome the problem? Can we solve the problem without supplementation? Is his question. Dr. Kurian? Thalassemia, vitamin D deficiency in thalassemia.
Vitamin D deficiency, as I showed here, is nearly 100% in the general population. So I do not know how it can be more common in thalassemia. Thalassemia is also, when you measure it, they'll find it very high, and that is just like it's similar to the general population. Thalassemia is a disease involving hemoglobin synthesis, and therefore I do not find thalassemia per se as a higher risk for vitamin D deficiency.
Then a lot of people are asking about dosage. Maybe one of you could once again clarify that perhaps, I think it varies from individual to individual, right? Or age wise, because
Deficiency,
people
no,
are asking for
it
dosage
doesn't. That is
recommendation.
why I said it is a consensus statement has been made now by the authorities, like WHO has done it, and Indian many associations have done it. But the basis for this is based on different groups. For example, as I said, the physiological absorption of calcium is reduced only when it is much lower level of less than 20. But bone mineral metabolism starts getting affected with high parathyroid levels, even at higher levels, and fractures occur at 30. So that is why, by consensus, 20 to 30 is considered as insufficiency, below 20 is deficiency, below 12 is considered as severe deficiency.
Dr. Pranita, Nirmala is asking about bone screening, and she says, can I get the difference between DEXA scan and bone mineral densiometry test? Which is better?
So both the DEXA scan and the bone density meter, both are the same thing. They are basically used to screen whether how weak your bone is. Like older adult, they have this weakness of the bone, and which is known as osteoporosis. So the DEXA scan is the main investigation to find out the level of osteoporosis. In that, there are 3-4 cutoffs where we say that the minus 2.5 is the cutoff to start the treatment for osteoporosis in that age group.
So there's an added question by Yasnitya who says, is there a specific questionnaire to assess the osteoporosis, or are there any other tools which are available with doctors to assess?
Yeah. So we assess osteoporosis on the basis of few things. One is high risk group. These are the high risk group who are more prone to fall. Number two, when already patient has a fragility fracture. Fragility fracture are the one who have the person have gotten a fracture with very low impact. For example, they are just sitting and had a fracture. So these are the people who, even if we don't do any DEXA scan, we know these are the people who need the treatment for osteoporosis. The third group are the people who are requiring very high dose of steroids, where like in autoimmune disease, they also don't require DEXA scan as such, but however, to treat for osteoporosis, because steroids is associated with high risk of osteoporosis.
This is an interesting question because a lot of teenagers and young adults, especially women, they apply a lot of sunscreen when they go out. Ritu is saying that how do we change this that hinders vitamin D production, Dr. Kurian? Is there any other alternative to sunscreen?
No, I'm not. The point is, if you are using sunscreen regularly, ensure that you take replacement vitamin D at the doses that you have been required. That is around 600 to 800 international units. People who use it for their own, they have their own reason to use it. I hope it is justified. Unjustified use of vitamin or sunscreening agents should be avoided. But if they are justified in using for reasons, because of many reasons can be there, uh, people are working in the hot sun for a long time require sunscreen agents, and that is protective for them. Let them use it, but when they use it, you must know the side effect of it is that vitamin D conversion is reduced, and therefore you have to take your replacement dose of vitamin D.
So again, there are same questions which are asking like, once we start supplements, is it for lifetime? How do we, especially vegetarians, as you mentioned, Dr. Kurian, that they perhaps have a limited choice. So what should the vegetarians in particularly do to have improve their vitamin D efficiency in their diets? Is raw garlic useful? So people are citing like different food items also. So would you like to quickly wrap up?
Yeah, generally, vegetarian diet is short in vitamin D. But therefore, but as you said, majority of it is from your is made from your body from the conversion of cholesterol. So many of them vegetarians may have normal levels of vitamin D in spite of being having nutritionally deficient. But the only food that is the amount of food items which are relatively high in terms of, even there it is small, mushrooms, almonds, etc., has been cited as good for higher levels of vitamin D in the and milk. Therefore, if you are a pure vegetarian, it is look my whole recommendation for a pure vegetarian is please check for vitamin D once in a when you go for a checkup on a yearly basis, and make sure that your levels are not too low, and ensure if you are low, supplement.
Shilpi Sarkar wants to know, Dr. Anish, whether vitamin D supplements are necessary in hormonal imbalance for patients with endometriosis and PCOD.
Again, like Dr. Pranita has mentioned, a lot of diseases other than the bone and muscle have been linked to vitamin D, but nobody has been able to prove that vitamin D deficiency is what is causing these diseases. Like there have been papers linking endometriosis, hormonal imbalances with vitamin D levels. So if you see those people, their vitamin D levels are less compared to people who don't have that disease. But it does not necessarily mean that vitamin D deficiency is what is causing that disease, and that if you supplement vitamin D, that disease will improve. So in those terms, there is no current recommendation or evidence to treat those diseases with vitamin D. Okay. On the other hand, since like Dr. Kurian said, the prevalence of vitamin D deficiency is somewhere around 50 to 60 or even 80%, which means people with endometriosis will have 80% of them also will have deficiency. So it is a good idea to test them and treat. That's all. So other than that, there is no specific role for giving vitamin D supplementation to people with endometriosis.
Apichit has asked a very relevant question, that why do we not have vitamin D education awareness programs in our urban and rural areas? Why aren't there enough?
I think that is what you are doing now. One of the initiatives is this, but you can expand that to probably even high schools and other community areas where people come. So maybe rural areas also need this kind of awareness programs. That's true.
So there are, I think, maximum questions on the use of sunscreen and diet. So somebody's asking that people with darker skin, do they need more sun exposure for vitamin D?
Yes.
Yes.
The pigmentation of the skin has got a negative effect on conversion. Therefore, highly pigmented people are more prone to develop vitamin D deficiency than fair skinned people.
Again, I think all these points you've already addressed in your presentations, like if I catch frequent respiratory infection, will vitamin D dosage help me? If I have, what is the relation between insulin resistance and vitamin D? So I don't know whether we should again.
So as
Somebody, sorry, yeah, if you want to add quickly, yeah.
See, we have already discussed this as vitamin D is so prevalent, so that even if we are having the low immunity, the vitamin D may or may not be low. That doesn't mean there is a direct causation of respiratory infection by vitamin D. And as I give vitamin D supplementation, the flu will go. So that causation link is still not well established. But only one thing is proven, that it has some anti-inflammatory action. So, for example, those people who are going for a screening for vitamin D and they are found deficient in vitamin D, it's better to just treat it.
Jagannath wants to know, is there any connection between the fungal infection which many people get in their big toes or their fingernails? Is there any connection with vitamin D deficiency?
No, there
Fungal
is no such
infection?
connection which is directly linked with fungal infection.
Mhm. And patients with recurrent immune compromising, is that also due to vitamin deficiency, or is it a myth?
No, again, it has a role in immune function, but it's actually, although it's a vitamin, it has a lot of hormonal functions. So in that way, there is a link to immune activation. But again, there is no proof that if you give vitamin D, your immunity will improve or anything like that. There is no study like that, or nothing to recommend like that. So there may be a link, but again, no use in treating with vitamin D for that purpose.
It may be
And
fair
this,
to say that there's a whole lot of information still lacking regarding vitamin D and non-mineral metabolism and aspect of it. That is still a research area people are working on. And newer information is coming on a regular basis. So until that time, we are not able to say for definite, if you have a problem like that, should you treat it. But associations have been identified.
can calcium tablets be taken along with vitamin D dosage?
Yes.
Yes.
So some of the calcium tablets will have international, for example, 400 or 600 international unit of vitamin D along with it. So that can be taken.
Okay, so there are again, I think, another 100 questions left, and I can see they're all about food and sunscreen and related to backache, neck pain, whether it's all connected. So I think I'll leave all that to you doctors later once the program is over. You could perhaps answer them directly. And I would like to thank all of you, our panelists and participants, for joining today's webinar on vitamin D deficiency, myths versus reality, presented by the Naruvi Hospitals, Vellore, and the Hindu. Thank you all very much.
Thank you.
Thank you. Thank you.
Can we just one?
Yes.
Can you
Thank you.
send the link, YouTube link, please?
Yes, sir. Yes, sir. The Hindu team will do it. Thank you.
Thank you.
Thank you, sir.
Thank you, doctor.
Thank you, sir. Thank you.
Thank you.
Thank you.
I think it went off well.
Yes. Nobody is able to get in, correct? And get Harshad itself is not able to.
Most people are not able to get it. They're all filled up early, I think. If they have limited 100, then nobody can get in. It's not.